Thanks very much, Andy. That's great. And thank you everyone for coming along. So yeah, you've kind of heard my official introduction. I guess the unofficial version is that what kind of keeps my mind ticking over, and what I continue to be curious about is how things work in the real world, and both in my clinical practice and my various bits of research and the sort of grey stuff that happens in between. That's really what I'm looking at, is trying to address the thing where when you're trying to improve or change something, you get the retort of, oh, but you don't understand, that's not how it works in the real world. I'm trying to start from there. And also I sort of feel like, I mean, I know we were just chatting at the beginning, but I could have just let Mark carry on and take over, because everything he was saying about risk aversion and all those words, you know, I totally resonates. And so what I'm really hoping we'll do this afternoon is kind of have a conversation. I couldn't quite let go of the clinical academic hat, so I do have a few slides that I'm willing to show as provocation to the conversation, if you'd like to see them when we've introduced ourselves. But I'm totally up for going off piste and seeing where this takes us. And great to hear from all of you too.
So much, Sarah. Maybe I'll just work around my screen. So Mark, do you want to just say a quick hello first?
Sure. Well, I'm really delighted to be here. I thought maybe I was just coming to listen to something, but I'm delighted there's going to be a conversation, and wonderful to get to meet you, Sarah. So I'm a co-founder of an organization called Heart and Soul, which I would kind of describe more as a kind of creative community. And, you know, our sort of what we're about actually is believing in the power and talents of learning disabled and autistic people, and then just sort of, you know, creating environments and spaces where people can come together, they can develop creatively as artists, they can be part of a community or a scene, they can put on events. And as I said, the last sort of 4 or 5 years we've been dipping, well, more than dipping our toe, but getting quite deep into actually really understanding what makes people tick and what things they would like to change in their lives, and working alongside, you know, a number of different institutions, universities, groups of healthcare practitioners, and just exploring the possibility of how things might be different, and actually just having this sense that there is a possibility of actually people being listened to for I think almost for the first time. And I mean, I've been involved, you know, for over 30 years with Heart and Soul, and I just think some of the people who have power and influence actually their ears seem to be open in a way that I haven't really ever experienced before. So that's exciting me. And also discovering places like here and the human learning systems, you know, just like, wow, there's other people talking about these ideas. So I'm just really keen to hear what everyone has to say and feel some solidarity and get some, you know, potential new ideas and people to work with.
Thanks, Mark. That's perfect summation of what this space is trying to be. So you've landed in the right spot.
Good.
Saskia, quick hello from you.
Hi, so I'm Saskia. I'm a palliative care consultant in Dorset, and I'm really interested in how we can improve how we work by just being more human and relational with each other, whether colleagues or whether with people we're supporting, kind of citizens, families, communities. And I love all that you've talked about, Mark, in terms of the creative approaches, because I think there's so much there in kind of almost unleashing our creativity, whether we're the kind of, we're just ordinary people, normal people in community, or whether we're kind of professionals or whatever. I think there's just so much there in what you're saying about creativity. So lovely. I'll go over to Susanna. Hello, Susanna.
Thank you. So I'm Susanna Hill. I'm a GP down in North Devon, but been working in sort of end of life things for quite a long time. Still, feel really, really passionate about trying to improve care for people at home in the best way. I wear several hats, Sarah, and I just, as you were talking, so I work for Health Education England, and we are trying to do some fairly radical work there about how we work with our GP colleagues and do some sort of quality assurance work in a totally different way. And it just when you were talking, I was just thinking, those are the barriers that I come across all the time, that we're trying to just help people reframe and rethink about how to do things in that setting. And even, colleagues I really, really respect are struggling about how to manage that change in perspective. So so I'd be really interested to see how this goes. The other bit that I hope I can indulge, because I feel really privileged to be here. I was listening to Mark and to what you said. So I chair a community development CIC for our community, and it has been life-changing and life-enhancing for me, I think, to work with people who don't work in healthcare, who have very different perspectives on what makes life better. We're doing some really exciting work with our local art studio, starting to do some work with young people with mental health problems who've come to the GP practice. So there are 16, 17-year-olds who are lost, really, I think, in lots of ways. And actually just seeing how that is growing has been so wonderful, really, to see the links and the building and the confidence that some people have got out of just doing something that really on paper is not very complicated, but actually to see some of these girls in particular come into the art studio and start to talk in a way that I would never imagine they could when I see them as a doctor has just reinforced that thing about how important it is to tap into what people really are. I think so. I'm really excited to be here. Thank you. Sorry, that's a bit of an indulgence.
Not at all. No, that was, I don't think it's unfair to say that was just awesome. So thank you. I'll come to Anna next. You're on my screen.
Hi, I'm Anna Whitehead. I'm currently developing a portfolio career. So part of what I do is one-to-one coaching on work-related topics. And I'm working as an associate coach for Genius Within at the moment. So they provide coaching for people with neurodiverse conditions to help them be the best that they can be at work. And I do kind of consultancy work as well, and kind of just following my interest to see what sparks. And I'm really interested in kind of making connections between people as well as between things. And that was actually kind of one of my intentions for this year, is kind of I was feeling a bit disconnected by the end of last year, kind of having worked at home for nearly 2 years and thinking, how do I make more connections? So I really liked what you said on the podcast about proximity, and not just being physical proximity, but finding other ways of proximity and moral proximity and proximity and interests. So yeah. That's me.
Thanks, Anna. And for those that weren't on the call when I said it earlier, you're the next podcast guest. So to have a look at that, folks, coming soon. Now, I don't know if you're there, but I think it's Georgina. Georgina, do you want to say a quick hello? Okay, I'm not sure if Georgina's there just because
Georgina's just popped a note in the chat.
Okay.
Hi, George.
Thanks, Georgina. No problem. Well, look, hopefully you're getting plenty out of listening in, and do keep adding to the chat box. Sarah, back to you.
Great, thank you. So like I said, I was really keen that we use this time as conversation, and I'm not going to make it like school and say who's listened to the podcast and who hasn't, but I'm really just giving you a kind of heads up that I had to listen to the podcast myself again, having said it, to kind of think about what I wanted to talk about with people today. So it's fine if at any point someone says, actually, can you explain that a bit more? But what I've done is put together some quite high level things that I thought I could share with you, and then allow group to have a bit of a kind of self-direction in terms of where you want to go with the conversation. So what I will do is I will just share my screen now, and I don't know if someone can just tell me if that is showing you the sort of title slide, which will obviously move forward.
That's working for me, Sarah. Yeah.
So great. So if we can just make my amazing NHS computer click from one slide to the next. So what I did, I was, not joking. I had another listen to the things that were in the podcast, because I just thought, oh, what was it that I really was trying to get to? I guess fundamentally for me, and quite a lot of you have already spoken to this in your introduction, so I think we're probably, on the same wavelength. What I'm trying to do, whether it's kind of very bottom up in my clinical work, or on a slightly grander scale in my academic work, is create a narrative that keeps banging away at the idea that because stories matter. And what I mean by that is thinking about how the stories we tell ourselves and each other actually shape what happens, and what shapes those stories is the experiences that we've had before. So when we think about making work better, it's really important to understand where things have come from, ourselves included, as well as where they might be going. And so I pulled out some of the things that I thought, oh, these are the ideas that I'm really trying to grapple with to make coherent. And what you've got on this slide, indulge me about the little Wordle, because I tried doing this and it didn't really work, which is why I put the other comments around it. But I did like the idea that this iteration pulled out making of the relational as its keyword. So that was just an illustrative point, because I think that is ultimately what we are doing. But on the right hand side of this slide, what I've got is the ideas of relational reach and relational glue, which were the key things I said. And I actually had a magpie on the first slide, because I everything I've just said about us being the product of where we've come from and our experiences is of course true for me too. And I'm very conscious that I'm trying to build on a whole host of reading and conversations and ideas that have come from other people. But the work I've been doing more recently, research-wise, has helped me develop these ideas that their current names are relational reach and relational glue. And what I mean by that is relational glue is the stuff that happens between people that makes or breaks things or holds things together. In palliative care, I'm sure Saskia will have had this experience many times too, and quite possibly in other fields of practice. People often talk about holding a situation or being with somebody, and it's this idea you can't fix it, but there's also something about glue that allows you to do things. So if you just think generally in life, there are things you can tease your friends about or share a joke about with some people in some contexts that you absolutely 100% couldn't with other people in other contexts, because the nature of your interaction is dependent on this glue that it, and sometimes it's stronger than others. Relational reach is about how do you develop connections across boundaries, and those boundaries can be again sort of multi-dimensional. So we often think about physical boundaries. If you think about healthcare, for example, there are literally hundreds of structural boundaries between different services. Again, to take palliative care as an example, ask anybody to have a discussion about what counts as specialist palliative care or what the referral criteria are, and you will instantly discover just how difficult negotiating and defining boundaries can be. But at the same time, they're the kinds of things that everybody has in their head that they know what they are. So I or anyone else might not be able to give somebody who doesn't work in palliative care a clear definition that makes sense to them of what counts as specialist, but we all think in our heads we know it when we see it. Now, that's kind of the worst sort of boundary in some ways, because not only is it there, but it's kind of invisible and undefined, which and what we want are situations where people can connect across those sorts of ideas. And then what I've got down the right hand side of the slide are things that I think these two ideas based on relationships are important for. So they're important for equity of social capital. That's what I mean by that is they're important if we want to make the opportunity to form the kinds of relationships that allow people to do the things that they want to do and need to do and are best for them and each other fair. So I'm not arguing for going back to a sort of stereotyped old boys club where it matters, you know, who you know, not what you know, is what matters. What I'm arguing for is thinking about how do we create a system where, yes, who you know matters, but everyone has equal opportunity to know the right people. And I would suggest that's going to come about through what I've called link lines of knowing each other. You know, it's one connection at a time, but we need a system that facilitates that and doesn't put up false and hidden or invisible boundaries between people. And the other thing that's really important, I gave the example of making jokes, but obviously there are lots of times in healthcare where something that is much more high stake than a joke falling flat or someone being offended by something you said. But you have to make a judgment about, is doing the wrong thing the right thing to do? And again, to draw on palliative care, we often see that when we're trying to individualize care for people, say at home in the community, where their priorities are in conflict with the so-called standard best practice guidelines for whatever the problem is. And actually, sometimes their priorities, which might be social things or psychological things as opposed to clinical, medical, physical things, need to be put first. And so and it's in having a trusting relationship that you can negotiate those things. On the left hand side in red are the things that I don't like in the current system. So I don't like the idea, which it's a very seductive idea, and I don't promise to never have been drawn down it myself if you were to dig through my history, but I don't like the idea of creating rules, because actually we're trying to create a sense of control, but actually it's an illusion because we can't control the situation. And when we were chatting just before we formally started, Mark was talking about risk aversion in the NHS and healthcare, and I think a lot of things that are done are around that, trying to create a sense of control. There are some very funny Twitter feeds, if you're on Twitter, about various standard operating procedures, my favourite of which is how to make custard without it exploding in an NHS kitchen, you know. But this sort of idea that if you create a standard operating procedure for anything, that somehow you've controlled it and therefore the risk has gone away, and of course we all know that's nonsense. Erosion of intangibles. I think another seductive idea is, how are we going to prove that a change is a good thing? It can take you down the quantitative measurable and not allow us to think about other forms of evidence. And again, to use a clinical example there, I remember when I was quite junior as a doctor being taught some palliative medicine by a very experienced consultant, and he was talking about the evidence-based medicine era and how we should, you know, how everybody talked about randomized controlled trials as being the gold standard of evidence, and pointing out that no one had ever done one for laxatives and constipation, but if anybody thought that meant there was no evidence, they were welcome to take a couple of packets of laxatives themselves and see what happened. And then my other one over here on my things I'd like us to leave behind is the transmit receipt checking model. Feel free to let me know if you have a better way of calling it. But what I mean by this is, instead of having dialogue and two-way communication, you have a model where unbelievable amounts of time are spent creating things, often in written format. So let's say, for example, discharge summaries when someone's leaving hospital to go home. They are transmitted somewhere. The expectation is that they're received somewhere. And every now and again, somebody will think it's important enough to check if they've been received, but there's no actual interaction, there's no dialogue, there's no discussion. I imagine it drives, for example, Susanna can tell me if I'm wrong, GPs absolutely mad. The number of discharge summaries you see, I've seen as a community palliative care consultant, where it says GP to do, and then there's this whole long list of things, some of which are actually completely impossible to do outside of a hospital. And, you know, again, it's an extreme example perhaps, but this idea that, you know, a conversation could have saved a whole load of trouble around that. So, and then the bits I've got as browny goldy colour in between are things that I've talked about in the podcast that are not in and of themselves necessarily good or bad, but things that I think we need to pay attention to, if we don't want them to impact on what's happening in ways that we aren't intending. I think most of the top ones are self-explanatory. The two at the bottom, the good and bad of fictional contracts. So I use this example in the podcast of working in a hospital where we are extremely limited on space to have private conversations with patients, and often precluding a conversation by saying, I'm really sorry, I need to talk to you about something that is difficult and sensitive, and I appreciate these blue paper hospital curtains are not soundproof, but we need to have this conversation, and having to draw a patient into this sort of fictional contract of the soundproof curtain that we all know isn't. And yet there is also a positive side potentially to this idea of fictional contracts. So sometimes agreeing with somebody, okay, let's start from this place. And I use this a lot in teaching with medical students. I say, you know, I know that we're going to run through this scenario and you're not actually stood in ITU giving advice on a really difficult situation, but let's enter into a positive fictional contract, so that to think about what it would feel like if we were there, so that we can do a dry run before you have to experience that for the first time. And the other one, the relational value, not relational excuses, that's I talk very much about doing things through relationships, but these shouldn't become an excuse for the system. So I guess what I mean by that is that what we should do is look at where relationships are the things that are making things work, and think, how can we do something to make the system facilitate that better, or to take that on and incorporate it in a way that makes things flow as easy as possible. There shouldn't be an expectation that people will always go the extra mile, and therefore the system doesn't need to change. And I guess that's a little bit like thinking about the backlash of the use of the idea of resilience, certainly within the NHS. There's a risk when you start talking about relationships or resilience that it becomes unfortunately changed into responsibility falling back on individuals, when responsibility needs to be in the system and the organisation, not just this idea that people will keep doing more and more and can kind of take the flak for everything. So I think what I might do is just stop sharing there and see, you know, what what grabs people, what doesn't grab people. Where would you like to go with the conversation? Anyone chip in?
So everybody's clear. The rules of the road here are just jump in. You can put your hand up, or you can just come off mute and dive in. So,
and if you want to try microphones all on, if we get lots of feedback, we'll have to switch them off, but we can try it. There's not too many of us here if you want to.
Well, I mean, I think trust is such an important word, Sarah, and seems to be the word that's so absent in so many of the interactions, and everything seems to be based on not trusting people and trying to make sure someone doesn't make a mistake because we don't really trust them. So that really resonates so powerfully with me. The other thing that I'm noticing, beginning to meet more healthcare professionals, and it's, you know, we're sort of sharing the culture of how things are at Heart and Soul with people, and sort of inviting them into a different type of environment. And it's about healthcare professionals never seem to have the time, or, you know, they're never asked how they are. It's such a kind of one-way traffic. They're just like supporting and caring, and I just think bringing people into a space where we can all be a bit more human, that's sort of what we're trying to do, and it really creates a very different dynamic. Even to the extent, you know, when we were at the hub, we one of the strands of work was called the Third Space, and it was led by a clinical psychologist, and she was just really keen to have a space where people came where their kind of professional labels were not on view, and it would be, you know, because we'd spoken to a group, well, people at Heart and Soul who use services, and we were asking them what they wanted to change, and they were just kind of really cross and angry. There was so much they were unhappy with. And then talking to the healthcare professionals, they were sort of seeming quite defensive and like, you know, not that confident about wanting to be in a space where people might be shouting at them. So we came up with the idea of a neutral space where you just enter as humans, without labels, and you do something together, you know, and you get to know each other, and you build a relationship from that space by sharing something. I mean, we had Bobby Baker, who's some of you might know, who's really she did actually get everyone to bake a cake, but it was just such a simple thing that everybody shared and talked about, and it just broke the ice in a way that if we'd gone in with the sort of top level, this is who I am, this is who you are, you know, this is what we do, it wouldn't have had the same impact. So I don't know, just wanted to share that. And it just so much of what you said was so resonant with me, and it's so exciting to hear the work you're doing.
Thank you.
I might chuck a tuppence worth in that just builds on that as well. But so the idea of, you know, we turned up as humans rather than with a role, and therefore we've taken the sort of, in a sense, the customer service provider relationship out the way, if you like, which I think is and often really helpful. One of the things that sort of connected to for me was, you mentioned responsibility there, and about, you know, not using relationships as an excuse for a bad system, or to excuse a bad system or whatever, which I suppose the thought that went through my head was, I agree, we shouldn't leave a bad system in place and have relationships find ways to kind of course around it. But I'm also kind of curious about this idea of what is the role of responsibility, because I sometimes think that actually we've so systematized things that responsibility ends up being an act of resistance, you know. And it's like, you know, how far could we go if actually we just turned up as humans who were responsible and like genuinely just took system out the way? So I don't know if you've any thoughts on that.
Yeah, I think that's really interesting, and I think one of the challenges is that when people do have a good idea that is very relational. So I think, you know, again, going back to that example of resilience, like the original idea is a good idea. The problem is that lots of people thought, oh, that's a good idea, and then they thought, right, how do we get this into a system? And it takes you back to that, oh, we have to have a structure around it. We have, I mean, they might not be rules in the kind of punitive sense, but rules as in the sense of norms of doing things. And suddenly you've got this idea of thinking of, say, me as a healthcare professional, as a human, gets translated into me getting an email every day saying, have you booked lunchtime yoga? Because this is what your organization is offering you to increase your resilience. And I'm like, well, actually, I'd quite like them to offer me lunch. That'd probably be better. So you know, it's it's trying. I think it is back to this thing about control and a reaction to uncertainty. And of course, we all have, you know. And if my husband was on this call, I can feel his eyebrows raising as he's like, yeah, because, you know, I know when you want to control uncertainty, because you start not just making lists, but making lists of your lists, kind of thing. So it's a natural impulse, but somehow I suppose what I wrestle with is, why is that what gets scaled up? The sort of the control, the structure, the systematizing it, instead of saying, okay, let's just let this happen organically. And I think it's also a perversion of the idea of what equitable is, that feeds into that, and the idea, you know, everyone has to have equal access. Well, first of all, some of us need more of some things than others, and some of us need more of other things than others, and we all start from different positions. But I suppose it is, and I would say that's where history comes in. You know, there needs to be an unpicking of how we've got here with those things. Yeah. So any other thoughts on my kind of first provocation slide?
I was just when you were talking about the invitation to lunchtime yoga, I was thinking of a strategy meeting that I attended towards the end of our residency at Wellcome, and suddenly, and everyone was on Zoom. Pretty much everybody apart from 3 people had their cameras off, and then suddenly this guy arrived, and we all had to do stretching, like very sort of I don't know, self-conscious stretching. I don't know why we were doing it, but I mean, I was with an autistic woman who she's not very flexible, and it was actually really uncomfortable for her, but it seemed a really performative act that was supposed to be good for us, but actually it was just a really good example again of power getting in the way, and we were being controlled. And I don't know who'd asked to be doing stretching at the beginning of a meeting, but it was just, it really struck me as just like, I understand where this is coming from. This is being enacted in completely the wrong way.
Yes.
Speaks
Yeah.
for
Yes.
Sarah, I just had two. I'm not really sure. I'm not trying to ask something. It's just sort of a commentary, really, I think, on 2 of the things that just struck me that you were talking about. One was definitely about the resilience thing, because I think it's become that trendy word, hasn't it? And everybody has to keep talking about it. And we've bounced this around endlessly at the GP school, because we've recognised, you know, that we've lost quite a few trainees, and how do we actually help them feel more valued, I think. We were putting together a programme around what were the resources that they might, so it was an offer, it wasn't a must do. And it was just trying to open up sort of different areas of thought for them. I think that's where we were coming from. We got considerable pushback from our trainees about, so you're telling us we're not resilient. So and we were going, absolutely not. You get this far in you know, through medical training, you're pretty resilient already. But, you know, we're all human beings, and wouldn't it be nice to have a slightly bigger toolbox? And that's been interesting to see how that's developed. And it's actually become, by gradually introducing it as an offer, actually that's been very well received. But we did have to work through it quite carefully, because I think we thought it was really good, you know, we'll do this, we'll do that, and then you kind of just got to do that step back sometimes, haven't you, and think, well, actually this isn't doing it for people. You've got to think what you're really trying to achieve. So that's been a really good learning thing for me. And I get endless emails coming through from Health Education England telling me exactly what you're saying, that I should be taking my 10-minute break now, and my timetable is geared up to 2 hours of calls and 3 hours of emails, and you've got to go and do something for an hour, and you just go, no, I haven't. So I just think it's interesting. So the other thing that I was just really curious about is this thing around professionalism and SOPs, and how difficult this is when you're trying to do something that you feel is fairly, sort of feels like it's common sense, and yet you keep hitting this recurrent barrier of, well, it's got to be tied up in an SOP, and the wording's got to be an and instead of a but, and a cross your T here and a dot the I there, and if you haven't done that, it's not any good, and that actually can be exhausting. And I think I mean, I'm so old that I feel that we have taken away the ability of professionals to say this is good professional practice, and it may not be, a bit like you were saying, what seems wrong can actually be right. And trying to work with other professionals, because I think that's easy for me as a GP. In many ways, as GPs, we have a lot more autonomy, and I don't have to work to an SOP for some of the, I have to work to what the GMC say I have to do, and that's fair enough. And I'm not, I'm not a cavalier, I don't mean it like that, but I think it is slightly easier for me to stand back and say, do you know what, if I want to give this drug that's been prescribed for a just in case box and put it in the syringe driver, I'm going to do it, I'll document it, but it's the right thing to do. The SOP says I can't, but I'm going to do it. But I'd be curious to know how we help our colleagues to move away from this risk averse and I sort of end up a bit schizophrenic, because I feel we have to be safe, and we have to help people who maybe are very new in their careers where they're struggling, but actually it can block some really good things. And I just wonder how we work on that. How do we do that?
I think that's a really important point, and I certainly don't have all the answers to that question. I guess I can give you some reflections. I think there is something that we just have to name about experience, and the more experienced you become, the more you are able to say, what happens if I don't do that? What's going to happen if I do that? You're asking me to do this thing, or I'm being told I have to do this thing in a certain way, what's the added value of that? And some of that is just about confidence and, the kind of how much energy you expend on things, because with experience you see what you, I was going to say what you can get away with. I don't mean that in a bad way, but what really does matter, you have a better sense of that. So I think that's definitely part of it. But I do think there's also something about kind of actually getting senior people to realize that acting professionally is not doing everything exactly the way they do it. And I think one of the most interesting pieces of feedback I've ever had from a trainee myself is being thanked for not expecting her to do things exactly the way I did it, but being open to the idea that there was more than one way of going about things. And I found that actually really helpful, because that is so important. And I think, often with education things, we're trying to support. So we've got good motivation that the less experienced or more junior people, but unless we change the culture of those who they see as being their masters in the broadest sense, they're not the ones who are empowered in this. And I do think there is something about, professionalism is another one of those very slippery words that I wonder if you pushed a lot of people, it's basically like, well, did you do it how I do it? Did you do it the way I think it should be done? Obviously, I'm being slightly devil's advocate there, but do you know what I mean? That's a sort of theme. And I think we need to change that thinking, and we need to try and get them to think, actually, okay, so you did this. Well, maybe I wouldn't have done it like that, but actually, is this a perfectly valid way of going about it? So those, like I say, I've not cracked that, but that's my initial kind of thought in response. Andy, you got your hand up?
Yeah, I just thought I'd chuck a tuppence worth in on this one as well. So with the same caveat you just gave of, what's coming now isn't the answer. But it seems to me that the way accountability operates is one of the major factors in terms of what you've raised there, Susanna, that conventional accountability, it seems to me, is you're accountable for whether you followed the procedure or hit the number or whatever it is. And if we know that people's lives are complex, then they're by definition not reducible to the procedure or the number. So accountability operating that way only guarantees that we do the wrong thing, which is perverse. So what would it look like if we instead had a system of accountability that was accountability for purpose? And that might be, if you like, if we're taking a scale mindset to that, it will lead us to panic of, well, how do we measure that? Well, the whole point is you can't. So it's back for me to the relational point that Sarah started us with, is, well, what we need to do is create a system of relational accountability. How do we create networks of peer support, and how do we explore, in a GP world, for example, how do we explore where we've got variations in practice without seeing it as, well, there's the right way to do it, and then there's everybody that's varying from that. Well, there's just variation. Let's understand it, And so I think accountability could very much look like learning, actually, in practice, if we chose to operate it that way.
Thanks, Andy. I'm going to suggest I just show you my other bits of provocation. I'm keeping half an eye on the clock, and then hopefully we'll have another 5-6 minutes to discuss. And I am conscious, I mean, some of you have joined from a palliative care specific perspective, and I'm not particularly focused on that, although I think all of these things apply in palliative care, but the offer, as I said at the beginning, is open if you want to know more about the palliative specific bits of my research as well. But let me just show you a couple more things. Just going to share my screen again and see if I can make this work so you can actually see it. So what you should be able to see is the joy that is the magic roundabout in Swindon. It is an actual real thing that as a 17-year-old, I and my friends lived in fear of having on our driving test. Thankfully, I didn't, if anyone wants to know. But it is something that I've been using, that my patient and public engagement group for my research study helped me develop as a metaphor for thinking about what should we be doing and how can we decide what to do and what we don't need to do to make more time for what we should do. And these, again, are not my ideas. Jeffrey Braithwaite and others have talked about the difference between work as imagined versus work as done. So work as imagined is that system design, the beautiful SOP, when everyone's agreed on the 3-letter words, whether they're and, but, and so on, of how things are going to work perfectly, rather like trying to navigate this roundabout with no other traffic on a beautiful sunny day, so it doesn't really matter what you do. Work as done is the full messiness of clinical practice, which is more like, you're in the middle of some kind of lightning, thunderstorm, snowstorm thing. There are people in all directions. You've never been there before. You didn't know this was about to appear at the end of the road you were driving on, and you're trying to navigate it. And it's a lot more complex. And actually, if you look at the roundabout carefully, it's impossible not to break part of the highway code, because if you are following it on one bit of the signposting, you are by definition going against it on another bit. So you can't just say, oh, we follow the rules and everything will work out. There has to be a different sort of navigation and negotiation. What my I presented these ideas as a way of thinking about relationships and the value of relationships and how things work in practice in the real world to my group. And they also brought out these two other ideas of work as declared and work as matters. So work as declared. So if you imagine you've gone in design from work as imagined to actually doing it in practice, work as done. Work as declared is what often happens where the people doing the work tell the people who either designed it or who are monitoring performance how it came, how it happened. And the trouble with that is that we're all primed to tell people what they want to hear. So often what we report back is as if though it worked fine, because we want to show that we're good at our work. But of course, if you do that, you can't then blame the system for not recognizing when it's not working. And what that can create is a sort of two worlds. So you've got this one loop going around those three bits, and then you've got another bit that's work as matters. And the example I go to for that is thinking about things like appraisal in workplaces. And I have had so many conversations on both sides of the appraisee, where we have a very productive conversation and then we say, all right, now we've done the bit that matters, let's fill out the paperwork. And we've just created two entirely separate things where we don't even bother attempting integrating what we report with what we feel really matters. And I think that's a challenge for all of us. Something else I wanted to show, and I'm conscious this is a super busy slide. So this is a whet your appetite slide. I have taken everything I've been talking about and I'm playing around with something called activity theory, which is what gives you these beautiful triangles and circles and things. And I'm currently doing a research study that brings together community professionals, general practice, acute medical unit professionals, palliative care professionals, psychiatry professionals, mental health professionals of all sorts, using both palliative care and serious mental illness as examples of where relationships really are the intervention. And we are looking at everything you can see on this slide together and looking at, I've collected people's stories. I've done about 100 interviews with people of all those groups, looking at what people talk about and where it comes and trying to come up with a vision of how things could be different. So if anyone's interested in that, then do keep in touch, because I find it so helpful to try and talk to other people about it and to develop my own thinking as well. But what I just wanted to finish me talking on were these two things as my final provocation. And this top quote is something I said in the podcast, which I still think about an awful lot. Imagine a world where if someone said they were going to do something, we could all trust it would happen in a timely manner. Imagine how much time we would all save if we got out of that transmit, receipt, check system that I talked about at the beginning. And I think this speaks to what Andy and the rest of you have been saying about that, professionalism and judgment and trust. The other final thought I'd like to leave people to ponder over is this idea of a little bit of heaven for the few versus kind of show us the money to do things. And a little bit of heaven for the few was the title of some research done in Lancaster a long time ago now. In their end of life observatory, they published a book, and this was the title, and they were talking about how unevenly hospice and specialist palliative care is distributed, and that's mainly because a lot of it is charitable funded, and so there is much more where people are richer, to be blunt about it. And although it was done a long time ago, I think the essence of that unfortunately does still hold true to a great extent. And the show us the money is something which palliative care, I think, as a field, as a discipline, I'm not sure what the right word is, struggles with now. We've spent so long trying to convince other parts of the healthcare system how what we do is really valuable and important, that we've done a lot of things for nothing. But maybe there's an unintended payoff of that about it actually paradoxically means things are undervalued. And I think one of the really difficult things in all of this stuff I've said about relationships and about seeking to improve the system rather than devolving responsibility to individuals to fill the gaps is when do you say, let's just get on and do it, and when do you say, no, you need to integrate this into the system because otherwise it's not going to be fair. So I'm not sure how coherent that is yet, but I thought this was a safe space to share my forward thinking as well as the stuff I've spent longer on. I will stop sharing again there, and just got a few minutes if anyone would like to chime in with some last thoughts.
Please do jump in, folks, if you'd like to. While you're maybe conjuring up some last thoughts, I'm just going to say thank you to everyone, but I guess especially to Sarah for taking us through that and getting us into a conversation today. So thank you, Sarah.
No problem.
Would anyone like to come in before we draw ourselves to a close?
Sarah, I suppose I just wanted to quickly to say, I think we know, I mean, if anything has taught us over the last 2 years, the value of relationships, the value of the conversation rather than the email, the endless emails we get, which seem, they're quick, they're easy, but they don't help us build the relationships that really make a difference to healthcare. I mean, the ability to phone somebody up and say, I just need some help, or can you do this, or what do you think I should do, is so enormously bigger than the email which you just sort of throw out. And yet, we are getting drowned in more and more and more of these emails. And I was thinking about the discharge letters. You're absolutely right. How do we do this into, is it about keeping on, trying to keep those practices going? How do we lead by example? I was looking at Saskia, wondering how she manages as a consultant. How do you keep the relationships that matter, that make this, make things happen, make work worth going to? How do you do it, Saskia?
Asking people for help when I need it, I think, is a really helpful one.
Yeah.
I think if we're going to make it normal to be able to pick up the phone rather than send the email or fill out the form, then we need to kind of model that ourselves as well, I guess. So yeah, just being kind of more open about having conversations with people, and I find it quite easy to admit that I don't know everything, because I really don't. So there's something about kind of not needing to be the expert in it, but just kind of being able to ask someone else and have a conversation about it. I think there's something in that. I think, and the conversation earlier about maybe early in people's careers, it's helpful to have the standard operating procedures so we know what to do. Well, to me, that feels like that's kind of just training people into not thinking. Whereas if we normalise it, that you phone a friend, or you ask for help as and when you need it, and you learn that way, then that normalises that you're thinking about it, you're having agency, and you're pulling in support as and when you need it. So I don't know if any help.
No, and I think it's a bit about the phone numbers. It's really, but I mean, we are making barriers, aren't we? I used to have a health visitor I could phone up. Now I can only contact her by email. I used to be able to phone the midwives. It's an email to a central point that then gets triaged into a person that I've never met, and it is just so different and dehumanizing. I really feel it is, and it's listening to Mark's work about sort of coming into this space as equals, and we are making more and more barriers to things that actually we know matter, and I don't know how to get that idea through to people about how difficult this makes work. Anyway, sorry, it's a sort of philosophical thing. Just I ponder it on a daily basis.
I do too, Susanna, and I completely agree with you. And I guess maybe where we have to start is trying to understand what it is people are afraid of, or has that system developed because it's people, it'd be fascinating to know whether your midwives are just as frustrated. So has that system come about because there's something, I mean, afraid sounds a bit dramatic, but you know what I mean, there's something your midwives feel they want protecting from, or has it come about because somebody else somewhere has decided this is the way things are done, in which case resistance and revolution is your only option. But being serious, you know, I do sometimes think, asking that question, what is it people are afraid of, that yeah is a good place to start.
In the name of efficiency, isn't it? And it's how do you quantify the relationship, but you know, the value of the, and that's what you were saying, is it, how do you quantify it? And yet we all know it, but you can't count it, so it doesn't turn up on an accountant's spreadsheet. Yes. In terms of manpower, and that's the bit about how do you show the benefits of it and the loss. And I'd be interested in anybody, because it's, you know, whether you phone the bank or whether you know, it's all about number. I can't remember, I had to phone something, something the other day, I had to do 5 different, you know, choose this, choose that, choose the other, and it was 5 different versions of which number you chose before you ended up at the end point. And you just think, where is there somebody I could just say, can you just help me with this? It's amazing, really. We have